Welcome to the Health Channel, all health all the time. I'm Olga Villaverde, coming to you from the Baptist Health South Florida studios in Coral Gables. How many medications are you currently taking? Maybe a blood thinner, blood pressure medication, antidepressant, aspirin, and the list, it could go on and on. This is, by the way, polypharmacy. It's an epidemic among the elderly, and it can have serious impacts on a patient's health and can lead to adverse drug reactions or ADRs. That's what we're going to be talking about today. And joining us today to discuss what polypharmacy is, why it's so common, and ways we can reduce the risks is Dr. Ivan Pettiot. He is family medicine physician at Bethesda Hospital, joining us from our South Florida PBS studio in Palm Beach County. Welcome, doctor.
Thank you for having me.
And also joining me right here in the South Miami studios is Jennifer Miles Wynn, a clinical pharmacist with Baptist Health South Florida. Welcome, Jennifer. Thanks for being here.
Morning, Olga. Thank you for having me.
All right, so we got a lot to cover today, a lot to cover this hour, because this is something that we hear about all the time, and it's such an important topic because I think it's misunderstood, Jennifer and Doctor as well. So, what is polypharmacy exactly, Dr. Pettiot? Let me start with you.
Well, polypharmacy is commonly referred to the use of 5 or more medication. It is generally referred to prescribed medication most of the time.
Which is, if we can guess here, a large population taking that today, isn't it, doctor?
That is correct.
All right. And in some cases, it can be overdone, maybe overused at times as well?
Well, the degree of polypharmacy can definitely be overdone. Now, you're talking about 5 or more medication, but when you look going over 10 more medication, the risk of adverse reaction rise.
Exactly, and that's what we're going to be discussing this hour, the adverse reactions, things to look out for, and whether or not you really need all these medications. So, Jennifer, let me bring you to the conversation. I don't want to say it's an epidemic, but I've heard it can be an epidemic among the elderly to be taking so many. Why is that?
Absolutely, Olga. So one of the biggest issues that we're finding is as our population here in the United States ages, clearly chronic conditions, acute illnesses, handicaps of different kinds can become a significant concern and issue. And with our patient population endeavoring to be well in their lifestyle and also from medical issues as well, it's very commonplace for medications to be prescribed for the patients. And so because of that, we do tend to find in our older population in particular, but it's certainly something that we're seeing as a burgeoning concern in our younger population as well, that patients are being prescribed a large number of medications. In many cases, as Dr. Pettiot referenced, 5 or more unique drugs to treat each one of these conditions. And because of guideline practices that our physicians and our other prescribers follow, it's not uncommon for a patient on one particular condition that they're being treated for to be on several different medications.
All right, and we're going to take a look at who else is at risk, because it's not just the elderly. Let's go through the list and explain why
Absolutely.
these people are risk factors here. So being an older patient, which
Absolutely.
is exactly what you just said, Jennifer, and it's expected. The older you get, the more medications, but you're saying you're seeing it more now in the younger population. Having a long-standing illness as well?
Absolutely, yes. So any patients that we're finding that have chronic conditions, which is our next topic there, having chronic conditions and or handicap, these are certainly going to be areas where we'll definitely see patients being placed on pharmacotherapy in order to treat it, as well as coming into contact with their practitioners being prescribed medications as well, yes.
And at least one contact with a general practitioner within previous 2 months?
Right. This is something that we're finding that's becoming increasingly common, is that unfortunately where lifestyle modifications may be suggested in previous encounters, more and more patients are experiencing prescriptions as being the means of addressing certain conditions.
And the last one, self-reported depression within previous year. That's a big one.
Correct. And that's something that our practitioners are being encouraged to ask patients more routinely now. It's becoming a standard of care as part of what's referred to as meaningful use, that our physicians and practitioners of other kinds, PAs, nurse practitioners, have to speak to patients about issues relating to mental health. And so depending on the patient's symptomatology and the things that they want addressed, patients may oftentimes, yes, be treated for depression as well.
Now, Dr. Pettiot, something that comes to mind now is we're talking about prescription medications, but something that I wonder about is over-the-counter medications. So is it possible that this polypharmacy concept that we're hearing about, which is a universal theme, if you will, is also being applied to over-the-counter medications as well?
Certainly. many times patients will take medication over the counter, will be misunderstood. Those may not be medication, especially when those medications are being bought in herbal stores. A lot of patients will kind of not mentioning those medication to their physician, nurse practitioners, or PA, because they do not take those medications as a medication that can actually influence other medication they're taking or can have some detrimental side effect. So we should not overlook herbal medication, supplemental medication, and medication taking over the counter, because they can definitely influence the medication you're currently taking and can add to adverse drug reaction due to polypharmacy. It does add to polypharmacy as well.
And I wanted to piggyback on something that Jennifer just mentioned, which is we're talking about obviously the elderly, and the older we get, you know, we obviously need more medications, unfortunately. But she mentioned the younger population. Are you seeing that too, where the younger population is maybe taking more than 4, 5, 6 medications when it comes to prescriptions?
Unfortunately, what we're currently seeing in the demographic of disease in our country is the fact that the younger population are becoming more and more sedentary. That sedentary lifestyle, due to the way children nowadays are operating in terms of their physical lifestyle. Some of them no longer play outside the house. They spend more time playing video game. They spend more time watching TV. They spend more time in front of the internet. So their sedentary lifestyle has increased some of the chronic conditions that we typically see in older individuals. We're now seeing them in younger patients. So typically diabetes, for example, is a condition that typically seen, especially type 1 diabetes, seen in younger individuals. Now in type 2 diabetes is seen mostly in older individuals. We're seeing a shift to having type 2 diabetes in the younger population as well. This actually affecting the younger population. Now you're having a 16-year-old with diabetes, and they may also have high cholesterol, and that high cholesterol and diabetes added to the fact they may even having hypertension. And if you put all 3 conditions together, 3 chronic conditions, those 3 chronic conditions may actually take this younger patients that was, let's say, about 4 years ago, did not have any medical problem and was not on any medication at all. Now that young individual or that young person end up having 5, 6 more medication because of 3 chronic medical problem, and that what has reasoned the amount of that actually not even reason. I will say that what have influenced polypharmacy in our younger population right now is because of the fact of chronic condition typically seen in older individuals. Now we're seeing them in the younger population as well.
Absolutely. And I see it even amongst friends of mine who are my age, Jennifer, for example, where, you know, I'll hear, you know, I'm on blood pressure, cholesterol, I'm on a thinner, and I'm just going, wow, they're just getting younger and younger to start off these medications. And the next thing you know, they have a plethora every day. And that's a concern. That's a problem.
No, absolutely, Olga. And I mean, this is one of the reasons why we've put into practice certain things that we'll try to do with patients on a routine basis. When you come into the physician's offices, whether it's your primary care doctor or a specialist, when you visit the pharmacy, where we'll ask patients questions about things and do a reconciliation of sorts, basically, of their medications in order to ensure that we support them in the way that they need. To your point, exactly, because we're seeing this coming up in younger and younger populations, as Dr. Petiot said, you know, from patients that are younger like ourselves, older patients, and certainly into the pediatric population as well.
And I'm going to even continue with the concern and show you some stats that will kind of back it up, if you will, because I always say there's proof in the pudding, so here it is right here. Here's the proof. Metabolic changes, risks of adverse drug events. This is not the one, but I'm going to actually go through it myself then. Sure. These are why polypharmacy is such a concern. Number one, approximately 10% of all U.S. patients are taking 5 or more unique drugs. Correct. 5 or more. Here it is right now. Wow. Nearly 30% of older adult patients believed to be impacted by polypharmacy.
Exactly.
Estimated 20% of adverse reactions believed to be the result of drug-to-drug interactions thought to be linked to polypharmacy. I mean, these numbers have grown.
Absolutely, and there's even some debate on the validity of these numbers. There's a lot of back and forth that goes on within the medical community because of the fact that this is a burgeoning concern, despite the fact that this is something that we know is something that needs to be monitored. And so effectively, there are a lot of concerns within the medical community that we need to be looking more proactively at this because the numbers could be even larger than we think.
All right, fantastic. Now, doctor, let me bring you back into the conversation. We mentioned adverse reactions, and according to the CDC, each year in the United States, adverse drug events, harm resulting from medication use, of course, causes more than, wow, listen to this, 1 million visits to the hospital emergency department. Does that number surprise you?
Not at all surprised. And those adverse events or adverse drug reaction do occur, and especially we're talking about polypharmacy, we know it's affecting the elderly populations more, but the reason for this high risk of adverse event in the elderly population is due to multiple physiological changes that do take place, that do happen in the elderly. One of them is metabolic changes. When talking about metabolism, we're talking about the process of the body on the food that we eat or the medication that we ingest. So by the time we actually take a medication by mouth, that medication go through metabolism, which is the processes that the body take. The body actually, the way the body affect the medication. So you take the medication by mouth, it gets to your stomach. Your stomach go through certain processes to break the medication down. That medication has to be absorbed to reach its intended target. So one way the medication has to get to its intended target is to get to the circulation system. For example, it has to get to the portal vein and get to the liver. And from the stomach, the body goes through certain processes. Now the medication has to get to the liver as well to go to certain processes. And from there, from the liver, the medication is dispersed throughout the body and reach its intended target. And afterwards, the medication has to be excreted to the body, outside of the body. Now, if you have any impairment, any impediment of that medication from the time you take the medication by mouth to the time you get to your stomach, to the time you get to the liver, and to be dispersed and excreted, that will actually affect the duration of that medication in the body, and that duration of the medication can actually be misleading. So, for example, the medication takes too long to get to the liver, and that medication is not effective. It may be understood as if you need more medication. The dose of the medication need to be increases, and eventually that medication will get to the liver. The prior dose will get to the liver. It will get to the bloodstream. Increasing that dose of medication will actually predispose to having a high concentration of the medication in the body, leading to severe adverse reaction.
Exactly. And Jennifer, I mean, really, sometimes it's even lack of knowledge, a lack of education on the patient's part, and not understanding that, the liver's on overdrive at this point.
Exactly.
And the liver can only metabolize so much. And that's from, my pre-med days, 101. We know the liver can only do so much. Speaking of the health aspect, which is what Dr. Petiot just mentioned, I'm also imagining with polypharmacy, the impact of, financial.
Absolutely.
That's huge as well, right?
Yes, and I mean, certainly we think about that from the standpoint of our elderly population in particular. We talk about the physical epidemic that this can take on our older patients, but certainly the financial implications are incredibly important. Mm-hmm. When you're dealing with a population that's living on a fixed income, but also trying to juggle with that the responsibilities of taking care of addressing the chronic illnesses that they have, certainly the more medications we add is not only a burden to them from a physiologic standpoint with the metabolic concerns, but from a financial one as well. So those are certainly things that we try to be sensitive of within the medical community, and definitely with us as pharmacists, we tend to find ourselves on the first line of assisting patients with that, because we are the ones ultimately that are prescribing, or I should say dispensing the medications for the patients. We certainly do feel a lot of that and the impact it has on our populations.
Absolutely,
definitely.
Absolutely. So much to cover here, and it's just so important to create awareness about this. All right, so coming up, we're going to walk through a patient example couple of patients who were taking multiple medications and experienced reactions. Plus, we'll talk about some of the medications that are considered inappropriate. And we're going to cover that when we return. You're watching the Health Channel, All Health, All the Time on South Florida PBS. If you have a question for our experts today, please call us using the toll-free number right there, 855-796-4475. We'd love to hear from you. Don't forget to visit our website, allhealthtv.com, where you can watch a live stream of the Health Channel, submit questions for the experts, and watch videos from previous episodes. We'll be right back. Stay tuned.
The city of Newark, New Jersey recently reported high lead levels in the water of thousands of area homes.
Drinking water often takes a long journey after it leaves local treatment facilities, potentially picking up a number of unwanted contaminants along the way before it gets to your home.
In an effort to help the Newark community, Pure has donated almost $500,000 worth of filtration systems. Pure's faucet filters remove 99% of lead and reduce over 70 other contaminants. Learn more at pure.com.
You have heard about breast cancer, but do you know BRCA? BRCA stands for Breast Cancer Susceptibility Gene. Everyone has BRCA genes, but some women inherit BRCA genes that have a mutation or a change. Women with this genetic change have a greater chance of developing breast and ovarian cancer than other women. About 50 out of 100 women with a BRCA1 or BRCA2 genetic change will get breast cancer by the age of 70. CDC offers a confidential web tool called Know BRCA that women can use to learn their risk of having a BRCA gene mutation. Learning your risk for a BRCA gene mutation allows you and your doctor to make important decisions for your health. This may include genetic counseling and testing, enhanced screening, and other methods to reduce your risk of ever developing breast or ovarian cancer. Enter your family history, learn your risk, talk to your doctor. Visit knowbrca.org to find out more.
Us lives here, where we can find common ground, big enough to dance on. For a better us, support your local Y today.
Addiction is a dark place, but just as each new day breaks, there is light. A light that illuminates the people by your side. Out of the darkness, you are walking with 22 million others struggling with addiction. The cure to darkness is light. The cure to stigma is love. And the cure to disease is treatment. Join us as we walk into the dawn of a new day. Together, we are stronger than addiction. Learn more at chatterproof.org.
Welcome back to the Health Channel, All Health, All the Time. I'm Olga Villaverde, and with us is Dr. Yvonne Petiot, family physician at Bethesda Hospital, and Jennifer Miles Wynn, clinical pharmacist with Baptist Health South Florida. If you have a question for these experts, please call us using the toll-free number, 855-796-4475. We would certainly love to hear from you. All right, so this hour we're talking about polypharmacy. It's the concurrent use of multiple medications, and while it's more common in affecting about 40% of older adults living in their own home and about 21% of adults with intellectual disability who are exposed to polypharmacy. So, doctor, based on these numbers, what's the first steps when an elderly patient comes to your office and says they experienced a fall? Do you immediately check to see what medications they've been on to see if that caused the fall?
Certainly, this is one thing that should be looking into, but a fall is multifactorial. What I mean by this, there's multiple reasons an elderly patient will fall. Obviously, the cognitive and the physical decline can be related to the fall as well, but we should not overlook the medication patients are currently taking, because that could play a role in the reason why a patient is actually experiencing a fall. For example, if you have a patient with dementia and this patient is taking a medication that can worsen the dementia, if you have a patient with already have certain psychosis, the patient has schizophrenia, and you put the patient on a medication that can worsen their schizophrenia, all of that can affect the patient, increase the patient risk of fall. So by looking into those medication in the medication list, we can see whether or not there is any duplication of medication or a high level of medication highly susceptible to leading to fall.
All right, there's something called Beers criteria, doctor. Can you tell us what that is? And I'm going to show my viewers a graphic soon after.
So the Beers criteria is actually the standard regarding inappropriate medication prescribing. It was developed in the early 1990s by a group of medical experts in the United States and Canada. Those criteria has been revised over the years, but really what they look into, they're looking into the ineffectiveness of certain medication and the high risk of adverse reaction related to those medications. The criteria itself is actually breaking down in 3 different components. Number 1, medication that should be avoided. Number 2, medication that can be considered inappropriate in the elderly population with certain medical condition. And number 3, medication that should be used with caution.
Fantastic. All right, doctor, thank you so much. And we actually also have a list of inappropriate medications and some of the complications they can cause. We want to go through them. Jennifer, let me bring you in. Sure. Tell me what the interactions here can be.
Absolutely. So as far as Dr. Petio mentioned, he's absolutely spot on that there is medications that as patients get older, we certainly become concerned about and the reactions that can occur. So for example, some of the common anticholinergic medications, these are concerns to us because of some of the side effects that they can have on the patients, such as dry mouth, constipation, urinary retention, sedation, which as you referenced earlier with fall is absolutely something we're going to be concerned about with our older patient. Confusion, delirium, agitation, absolutely. And so this plays into exactly what Dr. Petio was referencing a while ago with patients that might have altered mental status and some of the concerns that they may have. So medications that are commonly found in cough and cold products, things for allergy, over-the-counter, and by prescription, these will all be medications that used within an appropriate duration of time and at an appropriate dose are absolutely appropriate and acceptable for patients, including patients that are trending into the older segment of our population. But it's that long-term use of these products, which unfortunately, and especially with over-the-counter products, we tend to find a patient that's able to go into their local pharmacy and pick up Benadryl or pick up some of these other medications for allergy or cough and cold symptoms. Long-term use of these products is where we become concerned that they would fall into that demographic that would experience those side effects.
And I'm going to follow up on what you just said because we're going to talk now about it's fictitious patient report, okay? But we're going to go through this because it could be someone you know, or it could be you. And how would it go about fixing this kind of scenario?
Absolutely.
So here's a scenario I'm going to pose for you guys. A 68-year-old male, 68 male, history of hypertension, all right? Generalized anxiety, depression, insomnia, presented muscle aches, palpitation, maybe even some dry cough, dry mouth, blurry vision, all right? He was previously prescribed Vicodin, but he ran out of it months ago by his primary. Patient states that he used to take 10 milligrams of Ambien before bedtime for insomnia, but he also ran out of it 3 days ago and requested a refill. So he's been taking 2 tablets of Benadryl to sleep at night. Yikes. So let's look at the medications he's currently on. Watch this. This I find to be fascinating. I don't believe that one's it, so let's see if we can find the right one which states the medication list that he's on. There we go. Look at all of this, doctor. 10 milligrams of lisinopril, we know that's blood pressure. Amantadine, it's blood pressure. HCT has to do with blood pressure. And the list goes on and on. I think we have another graphic to show. Look at all of this. Aspirin, Ambien, Benadryl. What is your reaction to this? That's a lot.
Yeah, absolutely. And unfortunately, that's not uncommon for us to see when we take a look at patients' regimens, whether you're talking about in the retail pharmacy or for those of us that are clinic-based. That's absolutely the norm. And as Dr. Petiot referenced earlier, that's something that's not just in our elderly population, but we are starting to see this trending down into younger patients as well, that they're commonly being placed on products by their doctor, by prescription, as well as utilizing products over the counter as well to try and address some of the symptoms that they feel the prescription products kind of aren't taking that edge off of well enough for them. So it is becoming a big concern, and certainly that patient without any doubt is a candidate for the polypharmacy concerns that we're addressing today.
Exactly. And Dr. Petiot, I was counting now. I counted 12 medications for this 68-year-old male. 12 medications. I mean, I'm no doctor, but is there a better approach here?
Well, definitely, there is a better approach in this case. And if you're looking at this patient, for example, this patient has at least 3 medications that are considered anticholinergic. As Jennifer just referred a while ago, some of those medications this patient is taking has the same what you call pharmacological properties referred to anticholinergic, also called antimuscarinic properties. And those type of properties are not always good for the elderly population because of the symptoms that we just talked about, symptoms such as urinary retention, blurred vision, hallucination, and what have you. In that patient that you just mentioned, there is a lot of medication that are considered anticholinergic, but also this patient is taking also medication that are considered sedative. This is not a good thing for this patient. A better approach will be to look in terms of whether or not this patient has some duplicates of medications. If the medication is being duplicated, or some medication may actually fulfill multiple purpose, it's better to use one medication instead of using 2 medication. Another approach is to look whether or not some medication were used and no longer needed, so that those medications can be removed because they already fulfill their intended purpose, and those, that can be actually removed as we reconcile the patient medication list.
And speaking of intended purpose, can we also bring in to the conversation antibiotics? Sometimes I feel they're overly prescribed, I guess I'm going to say, and it's not always a good solution. Sometimes it can be more harmful than good. Would you agree, doctor?
I totally agree. When antibiotic is actually being prescribed for unintended purposes or misdiagnosis, for example, the upper respiratory system conditions, a lot of them are due to viruses. Although those viruses can actually lead to bacterial causes over time, but initially, when a patient presented for cold symptoms, we should looking into conservative management instead of starting prescribing antibiotic. I do not believe doctors' intention is to prescribe antibiotic unnecessarily. But sometimes you can actually feel pressed by patients because they will tell you, I know my body. So when I have that cough, it's bronchitis, I need to be on an antibiotic. But typically, a bronchitis is not a reason to be on an antibiotic because it is actually most of the time caused by, or generally caused by, viruses. And patient will tell you, yes, I know my body, I typically take it. But this is a teaching opportunity to remind patient about the fact that the condition you have, although this condition can actually progress to a bacterial cause over time, but currently what you have is a viral infection. Let's treat the symptomatic effect, and eventually over the course of maybe a few weeks, your body will return back to 100% or return back to baseline. Let's stay away from the antibiotic. Let's plan for a follow-up in a week or so that we can kind of looking into your progression. Have you gotten better, or or your condition has worsened? Whether or not further testing needs to be done to ensure that there is not a lingering bacterial infection that has later on occur, but not initially was present, so that if the antibiotic is truly needed, that can be actually being given. Now, if you actually if an antibiotic is being prescribed unnecessarily, we are actually doing the patient put the patient in a disadvantage. Why? Because that antibiotic, now that we're giving to the patient unnecessarily, his body will get used to it. Certain normal flora will get used to it, and that antibiotic later on will not be able to fulfill his needed purposes in the future if the patient getting sick, because now the patient develop what you call antibiotic resistance, and this is not something that we want, because we do not have that many antibiotic available. So if we have a patient with multiple antibiotic resistance, we may have a difficulty treating this patient.
Absolutely. I'm with you 100% there. When it comes to my children, I say, is it viral? Can they fight it? And when I hear yes, fight it. Even if there's a fever, you fight it. And that's what the body is made to do.
Exactly.
All right, we're going to continue the conversation. We're going to take a quick break. We're also going to talk about the dangers and health risks of combining medications. And maybe you're probably wondering, okay, what can I do about it? We're going to tell you what you can do. And when we always tell you, at the end of every segment, you're watching the Health Channel, All Health All the Time on South Florida PBS. If you have a question for the experts, please call us using the toll-free number 855-796-4475. And please be sure to visit the Health Channel at allhealthtv.com to watch a live stream of the Health Channel, submit questions for our experts, and watch videos from previous episodes. We'll be right back.
1945 to 1965. People born during these years are 5 times more likely to have hepatitis C, a leading cause of liver cancer. And people can live with hepatitis C for decades without any symptoms. The good news? Now, treatments are available that can cure hepatitis C. So if you were born from 1945 to 1965, talk to your doctor about getting a blood test for hepatitis C. It's the only way to know.
Everyone deserves a decent place to live.
Everyone.
When a future homeowner partners with Habitat for Humanity to build or improve a home, they build a better future for themselves and their families.
For my family.
For my family.
For my family.
With a little help, we all have the potential to stand on our own.
Potential.
Potential.
Visit Habitat.org to provide help to families like these today.
C stands for courage, collaboration, compassion, and sometimes even cuddly. At Miami Cancer Institute, C also stands for Cure, world-class cancer care right here at home. Learn more at miamicancerinstitute.com.
Overuse and misuse of antibiotics promotes the development of antibiotic-resistant bacteria. Every time a person takes antibiotics, sensitive bacteria, bacteria that antibiotics can still kill, are wiped out. But resistant bacteria are left to grow and multiply. Though antibiotics are completely ineffective against viral infections, like the common cold, flu, most sore throats, bronchitis, and many sinus and ear infections, they are still commonly and wrongly prescribed. Smart use of our antibiotics is key to controlling the growth of resistance. It's estimated that of those patients who visit an outpatient provider in the United States, over half of antibiotics prescribed are inappropriate.
Welcome back to the Health Channel, All Health All the Time. I'm Olga Villaverde, and with us today is Dr. Yvonne Pettiot, family medicine physician at Bethesda Hospital, who is joining us from our PBS studio in Palm Beach County. And joining me here in our South Miami studio is Jennifer Miles-Wynn, clinical pharmacist with Baptist Health South Florida. If you have a question for any of these experts, please call us using the toll-free number, 855-796-4475. So we all know it's inevitable. The longer we live, the more predisposed to develop medical conditions, multiple ones as that. And some people are born with medical conditions that require multiple medications as well. But the key is to work with your doctor to determine which course of treatment would be best for you, not your neighbor, not your aunt, and not your grandmother, for you. So let's talk about this, doctor, if we can. How can patients help lower their risk of polypharmacy? Because they're influenced a lot by, what they see, the lack of education, who tells them this, who tells them that. What do you think the protocol should be?
Well, the protocol should be is from the time a patient arrives at his doctor's office. Typically, a patient comes to the doctor's office with a complaint. The complaint can be a sore throat, a cough, refilling my medication. But the intention at that visit should always be for the patient that, you know what, I'm bringing you the list of all the other medication that all my other specialists is giving me. Also, I'm bringing you the list of medication that I'm actually taking over the counter as well, whether or not it's a Tylenol, is an ibuprofen, is a Motrin, is an Advil. Because you have that ache overnight, you were passing by Walgreens, you pick up that medication, but you know what, it wasn't a medication prescribed to you by your primary care physician or by any other provider. It's still important that you mention that to your primary care doctor or any provider that's seeing you at that visit. Also, if a friend has mentioned this particular supplement to you, that particular vitamin that you're currently taking as well, or whether or not, by curiosity, you reading in the internet, you reading some medical literature, and you feel, this medication, kind of talk to my condition, let me take that medication. When you're starting this medication, it's also important to let your primary care physician or any provider taking care of you know, so that they can actually looking into the duplication of care or duplication of medication, also looking into whether or not this medication is appropriate for your medical condition, whether or not those medications can exacerbate your medical condition, to ensure that you properly being advised which medication to take and which one not to take. So this is going to be a teaching opportunity and an opportunity for your physician to go over your medication as well in every visit to ensure that the list of medication you're taking has minimum risk of adverse reaction. Although that list of medication may be considered polypharmacy, but the degree of polypharmacy will be mitigated during that visit, because although you may be taking 12 medication, but it's 12 medication it's 12 medication that are needed, but it's not medication that you're taking unnecessarily.
And Jennifer, do you think it's a good idea to stick to the same pharmacy and stick to just like the same doctor so they're aware of everything that's going on in your life? Because a lot of patients tend to, flip and go somewhere else.
Absolutely, and that's one of the things that we highly encourage patients to do. We absolutely encourage patients to ensure that they try to stick to the same pharmacy. This was especially a big concern when we were at the heights, and arguably can still consider it a concern today with opioid prescribing and use of certain types of medications, that we encourage patients try to stick to that same pharmacy routinely, and also trying to avoid situations in which they increase their risk of polypharmacy, like frequently visiting the ED, urgent care centers. Trying to go to your primary care doctor and maximize that relationship as much as possible. Not only is there already an established rapport there with that clinician, but also with that rapport, they understand your health conditions, they know medications that you're already on, and so it'll reduce the likelihood that you'll walk out with 2 medications from within the same class, which is not uncommon for us to see our patients ending up on 2 of the same types of medication for cholesterol or multiple blood pressure medications. So these are definitely things that we ask patients to try on their end, to partner with us as clinicians to try and mitigate some of those risks.
And possibly even keep a detailed account of what you're taking. I mean, they even have apps for everything at this point, but they have an app on the phone where you can have a detailed, explanation of what you're taking, so there's no miscommunication, there's no mistakes.
Absolutely, and we encourage patients, many of our patients, whether you're talking about younger patient populations and some of our patients that fall into the retired category, our elderly patients, are tech savvy and have smartphones, and they certainly, if at minimum nothing else, have caregivers. So we encourage the patients to be as independent as possible and employ things like medication reconciliations on those apps, carrying pocket cards that have that information written down, or having a caregiver like a family member or someone that's a close, personal friend, something to that effect, that can support them. But definitely The apps, as you mentioned, are a great alternative for patients to keep that information.
All right, and then this could be helpful as well for those patients who are taking multiple medications, and you and I know many of these patients. We're going to look at this video from the National Institutes of Health showing some steps that you can follow to take medications safely and manage them efficiently. Very important. Take a look.
All right, that's for high blood pressure.
Okay.
I take a half a tablet a day.
All right. 1/2 tablet every day.
When a doctor gives you a prescription, be sure to ask the following 6 questions. What is the name of the medicine? What is the medicine supposed to do? How and when do I take it, and for how long? What foods, drinks, other medicines, or activities should I avoid while taking this medicine? What are the possible side effects, and what do I do if they occur? And is there any written information available about the medicine? There are many reasons patients don't take their medication properly, ranging from simple forgetfulness to more complex psychological issues.
Some of the reasons that people seem not to take medication in an agreed upon fashion are the complexity of the regimen is number one. When I'm on 4 medications and I'm taking one of them 4 times a day and one of them 3 times a day and one of them twice a day and one of them with food and the other one standing on my head, and it really gets to be difficult.
Some conditions, by their very nature, present challenges when taking medication.
Illnesses that are most affected by when folks choose to alter how they're taking the medication are the illnesses that we can't feel. So people with high blood pressure, you really can't feel that. And so you're feeling pretty good. You perhaps even feel worse when you take the medicine. So you choose to alter how you're taking it.
There are a lot of reminders we've learned over the years of how to take our medication. One of the simplest ones is to have a drug diary. And on the diary with the numbers, today is the 2nd of January. It's easy to remember. Write down the time you take your medicine. And as you take your medicine, cross it out, put a big X through it. Just use that for drugs. Don't use it for going to the laundry or going to the movies or picking up your granddaughter. Just have a simple drug, like a calendar, and use it. There are some homemade you can use. There's the old egg crate, those containers that they give you. I like the plastic ones because you can really see through them. You can put your medications for the week in them and keep them on your kitchen table, wherever is useful for you to keep. I find they sell over-the-counter aids, little plastic containers with the days of the week written on them, and you just open them up and you've got your pills for the whole 7 days of the week.
Regardless of age or economic status, taking medication can be as integral a part of our daily routine as brushing our teeth or eating breakfast. By communicating with our healthcare providers and by accepting a greater responsibility in our own healthcare, we can learn to take our medicine safely.
Great story there. Dr. Pettiot, I want to direct a question to you. I know we only have a few more minutes with you because you have to get to the office and see your patients, and we do appreciate your time here on the Health Channel. How often do you de-prescribe medications, and how do you go about doing that as well?
Well, this is an opportunity that I have every time I see a patient. That opportunity actually presented is more actually, the opportunity is there, especially when you're seeing a patient for the first time. Your own patient, if you reconcile the medication on a daily basis, the job is easy at that point. You just have to ask, is there any other medication that I'm giving you right now? Are you taking any additional medication? Is there any other medication is being given by other by other physician, other specialists, or are you taking over the counter? And then in looking into the treatment that was started and see if the medication you started for that treatment is still needed. If the patient condition has resolved, then this is the opportunity at every visit to remove a medication that was for an acute condition, although you're going to keep the chronic condition. But if the chronic condition themselves has improve or resolve or being stable for many years, this is time to scale back on the medication you've been prescribing to your patient. For example, if you have if a patient has been taking ibuprofen and that was intended for less than 5 days, and you realize that in your list of medication this has not been removed, you need to ask the patient, are you still taking that ibuprofen? It was for 5 days. And sometimes patient misunderstood direction given to them at the moment when direction was given for medication, and may still taking that ibuprofen, which can lead to renal failure. So this is time to remove medication that no longer needed during that visit on the list of the medication has. This is called medication reconciliation. So pretty much every visit is an opportunity to pretty much de-prescribing medications.
Fantastic. Thank you so much, Dr. Pettiot, for your time. We do appreciate it right here on the Health Channel.
Thank you for having me.
All right. So when we come back, we are still going to have our conversation with our clinical pharmacist, Jennifer Wynn, and we're going to talk about things that basically change in terms of drug toxicity. That's very important to talk about. So that's coming up as well. You are watching the Health Channel, All Health All the Time on South Florida PBS. If you have a question for Jennifer, please give us a call using this toll-free number. It is 855-796-4475. Please be sure to visit our website, allhealthtv.com, where you can watch a live stream of the Health Channel, submit questions for our experts, and watch videos from previous episodes. We'll be right back. Don't go away.
Have you mixed your pain meds, your sleep meds, your allergy meds? Call the Poison Helpline. Has your child swallowed household cleaner, a chip of paint, a wild mushroom? Call the Poison Helpline. Have you been bitten by a spider, a snake, an insect? Call the Poison Helpline. Poisonings can happen at the home, on the job, or in the great outdoors. Call the Poison Helpline first to speak with medical professionals who can give you free personal advice anytime. Save the number, save a life.
Dear humans, I stand here today not for myself, but for every tail wagger, sloppy kisser, and curtain ninja. I stand here for each one of the nearly 4,100 dogs and cats killed in shelters each day, asking you to join our cause and help us make sure every best friend has a chance to meet one of their own. With Best Friends Animal Society leading the charge, and your help, we can save them all.
The purpose of clinical research is to help understand how the human body works and how health and disease come about. So we want to understand what makes good health.
I think women's participation in clinical trials is extremely important because we have an entirely different set of issues, whatever body system you're working with. It's different from a man and from a child, so there are certainly differences there that we need to understand and focus and realize that are specific to women.
Science has shown and taught us that men and women are different in a variety of ways beyond the obvious differences. Our organs are different, our level of our hormones are different, we respond to treatments and medications differently. Based on those findings, every single cell in a woman or a man's body is a male or a female cell, and those cells respond differently to different triggers to different treatments and to the environment.
Welcome back to the Health Channel, All Health All the Time. I'm Olga Villaverde, and with us today is Jennifer Miles-Wynn, clinical pharmacist with Baptist Health South Florida. If you have a question for Jennifer, please call us using the toll-free number 855-796-4475. So this hour, we've been talking about the dangers of combining medications, but another serious complication with combining medicine is drug toxicity. I'm not sure if you've heard of that, but otherwise known as combined drug intoxication, or CDI. Is there a difference, Jennifer, between, let's say, overdosing and the CDI?
Absolutely. So with an overdose, a patient may have too much of one particular medication that they experience those adverse reactions from. But with a patient that's experiencing a CDI situation, you may have two or more drugs that are interacting with one another, and again, will be very highly related to the polypharmacy topic that we've been discussing this morning, where those medications and the effects of each individual drug basically have a synergistic effect with one another. And so patients may experience a broad spectrum of symptoms that are just a cascade of worsening toxicities and side effects that the patient will encounter.
And something I think is important to note is a lot of people sometimes, friends of mine have told me, no, because my grandmother, my mother, she was trying to call the doctor and she wanted to know about the medication and she couldn't get through. She left a message, and then, you know, like the pressure and the fear of taking, and it's just so easy to go to a pharmacist. They are there, they're very knowledgeable. Here we have one, and you're there to answer any concerns for free.
Absolutely, and especially if it's the pharmacist from whom you receive your medications at your retail location, or if you have pharmacists that have a relationship with you through your physician's offices with clinics that we engage in often there, we can certainly be an excellent resource. There's also resources within the community, like Poison Control, for instance, is another excellent resource. But certainly if you have a pharmacist that you're working with already through a retail location, you absolutely want to try and maximize that as a source of information to help get you through that period where you may need to have some questions answered.
And also, I wanted to switch gears a little bit because, you know, we hear so much about the opioid epidemic at hand. How are you dealing with it? Is it challenging?
It can be. I mean, one of the things that has been great, there's been recent legislation that's been passed earlier on this year, House Bill 21, that has really kind of stepped up a bit of the prescribing. There's going to be some challenges around initial implementation of that. But if you see the statistics that are associated with it, 78 people dying per day, you know, it really is a challenge here in this country for us. We certainly want to balance out the needs of our patients that have true pain issues and concerns. But certainly we also have to take into account the responsibility there to do our due diligence as clinicians and to ensure that patients are on the right drug for the right amount of time and that it's having the desired effect for them. So it's a balancing act every day for us as pharmacists as well as for the prescribers, but it's something that we're really trying to work collaboratively on to, in the end, do what's right for the patients.
Absolutely. We have to create that awareness, and we're going to look at a video from the Mayo Clinic. They say it's best to avoid opioids for chronic pain, and especially for taking other medications as well. Take a look.
50 million. That's how many people in the U.S. suffer from chronic pain. Many turn to opioid painkillers for relief.
The evidence is not at all clear about the efficacy of these drugs long-term for chronic pain.
Mayo Clinic pain management specialist Dr. Mike Hooten says what is clear about these painkillers is the risk associated with taking them.
The problems of addiction, but also a related problem of accidental overdose deaths.
Morphine, oxycodone, and hydrocodone are commonly prescribed opioids. Dr. Hooten says they are very effective when used short-term for pain, for example, after a surgery. For long-term use,
there are a smaller group of studies that may show some benefits in certain highly selected groups of patients.
But for many cases of chronic pain, Dr. Hooten says non-opioid pain relievers combined with other therapies such as stress management can help people manage pain and maintain a high quality of life.
So is it difficult, Jennifer, or would you say it's difficult to kind of steer patients away from the opioids, especially if they're taking other medications and they have that chronic pain?
Well, we as pharmacists will try to do as much as we can to advise patients, particularly when we have a patient that's in front of us as someone that's a routine patient that we have a rapport with. So we'll try to maximize that as much as we can. We know that there's going to be a lot of groundwork that has to be done, though, by their prescribing team, particularly the physicians. So it's something, again, that's sort of a balancing act, if you will. But we try to do what we can to engage the patients and to educate them. We want them to be as much partners in the treatment as we are the clinicians. We're the experts in terms of the mechanisms of the drugs and the health conditions, but the patients are the experts in terms of their personal health and their needs.
You've been doing this for a long time. Do you have a story of possibly someone that came in and you just saw the list of medications and you went, whoa, and you just went alarm, alarm, and realized something's got to be done, and you actually helped them to reduce?
Absolutely. So as part of the job that I have, I'm very fortunate to work as part of an interdisciplinary team now with nurses and physicians. And so we engage in a daily routine of what's called transition of care, where we do evaluate a number of things for patients. And for my part, medication reconciliation, looking at the drugs for the patients. So on an almost daily basis, we do have a large number of patients where we'll see, long lists of medications, multiple blood pressure, multiple diabetic therapy. And so we will try to work together to reduce what the patient's taking.
Fantastic. All right, thank you so much for your time.
No problem. Thank you
Great
for having
stuff.
me
And
here.
please come back to the Health Channel.
Thank you so
really
much.
Important topic. And hopefully out there, if you have that whole list of medications, you can bring it to Jennifer and say, can I reduce them? Go from 12 to hopefully maybe 5, 4, 3, 2, and maybe 0 one day. All right, be sure to join us on the Health Channel next time. All Health All the Time on South Florida PBS. Follow us on Facebook and Twitter at All Health TV. And please be sure to visit our website, allhealthtv.com, where you can watch a live stream of the Health Channel, submit questions for the experts. They're always on standby to hear your concerns, and watch videos from previous episodes. Remember, we do this for you. I'm Olga Villaverde, and we'll see you next time. Take care.